So thanks for inviting me. I like the way oncologists live. I had no idea it was like this, Chris, you know. And I enjoyed oncology when I was a med student, University of Kentucky. I thought they were too smart for me to be an oncologist, you know. So I went into cardiology instead. But guys really have it made. I enjoy the milieu here. So
Actually, we went into oncology because we could not get into cardiology.
I don't believe that. Don't believe that. So I thank you for inviting me to come today. And I have a team that's here. We've been working on cardio-oncology for almost a year now. We found that this is a new specialty that's developing, and we found it was really important, and it seemed to be ignored by the mainstream cardiology community. And so I have some fortunate coincidences that occurred that made it possible for me to get involved in this field. And one thing is I'm a cardiac imaging specialist, self-appointed, and we do cardiac PET, CT, and MR. And we have the training program for Northside, and we have Dr. Rahmani here, who's part of that group, and we have a training program for USF. And coming up this July, we'll have a fourth-year cardiac fellow that'll be doing a year, and we'll have one each year. So we're real excited about having that program in cooperation with the University of South Florida. And we hope that this will be a big part of that for the fellows training. I think that there's a lot of opportunity in this field. Now it also turns out that one of my students who made good has basically gone to MD Anderson and is in charge of the echo lab there. So that gave me a connection, and then I spent some time at MD Anderson, and I had an opportunity to spend time with Dr. Bonches. And then Chris, our echo tech, has been to Dr. Bonche's lab and basically spent time learning, and now once you learn it, then you spend time teaching strain echo, which is called speckle tracking, and you'll learn more about that in a few minutes. And then Christina has been to the MD Anderson Cardio-Oncology. She's our PA, and she's been to the Cardio-Oncology course. And then Janelle has just absorbed everything she could in the office, trying to correct my spelling and my concepts in writing. So we do have a couple of handouts we're going to give you when you finish, so you don't have to take notes. You'll have the information on the handouts. So there's a new subspecialty, and we want to introduce that. And this is sort of an open curtain to show you, cardio-oncology. And so we want to tell you that I am officially a member of the International Cardio-Oncology Society, which I think that and $3.50 will get you a latte. But that was appointed by this group. That's a very interesting group. And you see the signature is from Vanderbilt, and the other signature is from Milano. And what's really interesting is there's a very active group of people in Milan who are very interested in cardio-oncology. And so we have a conference once a month with them online, which Janelle's responsible for. And I'm their host. And the people from Milan, basically, it's 3 o'clock in the afternoon. It's 9 o'clock for us. MD Anderson, it's 8 o'clock, and Utah is 7 o'clock. And we all get together and present cases, which has been very instructive. And one of my students also is at Moffitt, and that's Dr. McClanahan. And so she comes into the conference too. And then we have various visitors from time to time. So that's been a lot of fun. And after I got this appointment, I invited everybody there in Milan to come to La Buca, which is a great restaurant near the train station for seafood. And they were delighted to be invited. Unfortunately, I'm not there, and they're there, and I'm here. And so they said, when are you coming? And I said, well, I really don't know. But I felt like I needed to reciprocate. So I've got to get there sometime. And Dr. Chatur has volunteered to go with me. You know, so I'm very pleased about that. Well, we do have this consortium of cardiac imagers who are here together to support basically oncologists, you guys. And so these are the main centers that have participated in this, and we're real excited to have cardiologists that are just outstanding imagers in their field, most of them having the most compelling interest in echocardiography. But there's also interest in cardiac markers, highly sensitive troponin I, and the B-type natriuretic peptide. And so this group is the group that comes together, and I think this group, mainly spawned out of MD Anderson, has inspired us to put this program together. And so I thought I'd start with the first cardio-oncology case that I've seen, thanks to Chris George. And he said, well, I'll go along with this. And so he sent a patient to see me, and her name, she's a 41-year-old lady, and you can see that she was diagnosed with left breast cancer in February 2012 and had surveillance mammography and breast ultrasound, core biopsy, and you can see how she was classified, and she's premenopausal, BRCA negative, although both her parents, well, her mother and her grandmother, I think, had breast cancer. And so she's had Hashimoto's hypothyroidism, treated in 2004, iron deficiency anemia in 2009, hysterectomy in 2011, palpitations in the past, breast cancer in mother and sister, allergies to Keflex. She smoked a little bit, but not much, alcohol weekly, and she was on these medications, one of which is for hypothyroidism. She started chemotherapy March 8, 2012, and you can see the drugs that she was taking, and then she was on Herceptin for 1 year every 3 weeks. She's had a double mastectomy in 2012, radiation therapy to the left breast, which we'll talk about later because that's an area of interest also to cardiologists, is radiation to the left breast, and reconstruction, which is being planned. And so these are the ejection fractions that she had, and you can see that they're all pretty consistent except for the last one doesn't quite fit in. You say, well, what happened to that ejection fraction? And so that ejection fraction was 48%. Well, it turns out it was done in a center that is a diagnostic outpatient center that basically specializes in other things other than cardiology, and there's no supervising cardiologist for the echo tech who's a general ultrasound tech, not just an echo tech. And so actually we reviewed this and found that the angle of the beam for making the ejection fraction was totally wrong, and it was an unacceptable study because the heart was angled in a different direction from the beam, and so it just made everything wrong. And so she was basically sort of destined to stop chemotherapy because of this number, ejection fraction drop of 15%. So I presented a problem, and Chris said, well, why don't you see what you get? And so she came over here, and we decided that we would work her up a little bit, and so we did. We looked at her EKG, and she had nonspecific ST and T wave changes. We did a highly sensitive troponin I, which is negative. We did troponin T that was negative, and the B-type natriuretic peptide was 9.70, and that's just basically nothing in terms of BNP. We did an echocardiogram. We actually did sort of overkill because we said, well, this is our first case. Let's see what we can learn from this. And so we used the GE Vivid 9E, which is a big sucker that costs about $400,000. And then we had a little portable GE, and we did some imaging, and we did speckle tracking, which I'm going to show you what that is in just a minute. And the ejection fraction was 65%, back to where we were before. And the global strain, which we'll talk about in a minute, is minus 19, which is normal, and the regional strain was normal. And then we said, well, about 30% of people you can't get a global strain on. You just, you know, how difficult echo windows can be on certain people because of lung position, even, you know, ladies who have augmentation of the breast makes it very difficult. And so what are we going to do when we can't get a good image? And so we said, well, let's do the cardiac MRI because we've got to understand alternative evaluations. And so cardiac MRI is that. So we did ejection fraction on the MRI. We can also do this speckle tracking type thing on the MRI. And the MRI, it's really incredible, and I'll tell you the difference in a few minutes. And so we looked also, we said, well, while we're there, she's getting radiation to her left breast. And so that's the main left coronary artery right there, and the left anterior descending's right there. So let's just get a baseline of her main left and left anterior descending and proximal right. So we did get a baseline, and we've got that recorded and available for the future. If there's any question in the future that she's developed some fibrosis in her coronaries, we can recheck that with the baseline. And I have seen people that have had osteal main left disease, women, from a breast cancer radiation therapy, and had to have bypass surgery from that. And so this is a good thing to have this just in case for the future. So we gave her the terrific workup, and this gives me an opportunity now to show a couple of these studies. And so we're going to have to switch over here to the other computer. I actually brought my workstation with me so that I can show you these images, because they're so important to be able to see the images. This is an example of something we call speckle tracking, which actually puts these little dots on the endocardium and on the epicardium. You get these little dots, and it superimposes the little dots during diastole and during systole. And then the computer tracks those dots in terms of diastole, systole, moving into a central point of like a radius type thing, and it tracks those dots and records this tracking of the dots, and then translates it into several color code, including a big pizza you'll see in a minute, with several color coded things that we can read off of and find out how this heart is deforming during systole. And that deformation of the heart precedes, the decrease in deformation of the heart precedes a change in the ejection fraction. And that's the key. That's strain imaging, speckle tracking observations precede the decrease in ejection fraction seen with someone who has damage to their heart. So basically this is being used as a hypothesis now. And there have been several studies, but not enough yet to be able to document this. And so we're very excited about this. And you can see there are numbers that occur that are like minus 9, minus 25, minus 20, we have minus 19. And this is the form that we look at. And let me show you one of the other things that we show when we do that. And that's going to be this mouse. Yeah, there we go. So this is something that Chrissy did. And hey, that's good. And you can see these numbers, and these numbers are supposed to be minus 18, minus 19. If you get something lower than minus 12, and you see it consistently in several fields, in several areas, perhaps globally, that's indicative of pre-cardiac failure findings that precede decrease in ejection fraction. So this one looked great. This is a nice baseline for us. If this lady should have any problems in the future, we're all set. Let me show you her cardiac MR, which we did. Here's her standard echocardiogram, systole and diastole. And you can see some of the little speckles on there. And that's all pretty normal stuff. And the 3D echo, which we're not showing right now, has an accuracy that can find decrease in ejection fraction of less than 5%. And so basically the FDA has said on some drugs that if there are symptoms and if there's a decrease in the ejection fraction of 5%, that is considered cardiotoxicity. But unfortunately, 2D echo is incapable of detecting that. Actually 3D echo is what you have to use, or you use 3D MRI. And so we have ways of actually getting within those limits, which was kind of ridiculous of the FDA to define those limits in the first place, and no one can measure it. But now we can. And so this is a cardiac MR, which doesn't project as well as you do when you look at it on a workstation. But it really gives you, this is the gold standard for ejection fraction. And I'll show you the image that we do to produce that ejection fraction, which is a 3D image. Hang on here. Here we go. So we're sequentially beginning at the apex of the heart. Look, you can see that torsion. Beginning at the apex of the heart and watching it squeeze into systole, go back to diastole, and then move up, next sequence, next sequence, next sequence. And so we built a three-dimensional model. So then all we have to do is go through each one of these and identify epicardium and endocardium, and then the computer will basically generate a three-dimensional ejection fraction, which is within 5% of accuracy. And so this is incredible progress that we're showing you. Now that image that you saw was without dye. There's no contrast. We basically are using proton spin to make those images. And the protons that are in motion, in terms of the water inside the blood, has a different spin from the walls. And so we're able to identify that by using the MRI. Another thing we can do with MRI, which I'm not going to show you today, but it's possible to do spectral tracking. And what we do is we can actually take sections of the myocardium and take layers within millimeters of one another, and take one layer and put one spin on it, and then another spin on the second layer. And so we can have this grid that actually exists within the myocardium. It's not a superimposition like we did on the echo of phony dots that are trying to be tracked by the computer. It is actually a grid that exists on the myocardium that's been established by changing the spin. Now that's just amazing. And so we can use that and calculate speckle tracking from that. And the numbers are exactly the same. Minus 19, minus 20. And so it's very reproducible. Again, you can see this is a four-chamber with the left ventricle, right atrium, left atrium, and you can see how superb the identification is of the endocardium as well as the epicardium, the pericardial fluid, which is normal, and so forth. So these pictures.
So Eric, can the computer then take those images and do topographical analysis and give you a quantitative, sort of 3D picture from that, or do you?
Oh yeah, we could put that together
or
easily.
You still have to just kind of draw the lines.
We could put a 3D picture together for show and tell,
yeah.
And that's like our razzle dazzle stuff that we do. We do the same thing with CT, where we have 3D color coded. That's for the guests when they come through. And put that on the screen and want to rotate around. And so, but the real science is taking that stack and calculating the ejection fraction from the stack. So we had a plan that we put together for Chris's patient where we would get the ejection fraction, which we did, continue. We said he can continue the Herceptin therapy because the ejection fraction was normal and the speckled tracking was normal, the troponin I was normal, the B-type natriuretic peptide was normal. We may find out in the future that one of these tests is basically the bingo test, that if you get a BNP that's elevated, that's it. you know, but this is where we are right now, and we're trying to compare these tests. And you can see that the plan is to do these every 3 months and to do the echo of strain on completion, the Herceptin, and then yearly echoes. And then at some point following the main left coronary artery and the LAD, look for progressive stenosis or fibrosis. And so that's kind of the plan. Yes?
Why MRI not or angiogram?
Oh, you know, I was thinking that these patients, if we're following them for radiation damage, it seems like it wouldn't be a good idea to give them radiation to compound injury, you know, on top of that. So, you know, so I was thinking MRI, we could do that. We can give you beautiful pictures. And especially if we use this breath nav indicator, where we follow the diaphragm and sort of synchronize the images with that. And so I was looking for a no radiation procedure. Something really interesting is that to do the sort of strain imaging on the MRI, we can do that with something called Sense. That's some new software by Diagnosoft that basically, on one heartbeat, you can get the information you need, which sort of does away with the problem of MRI being very expensive and the throughput of MRI machine, because you just put them in, you do the one heartbeat, and you're done. You get the information. So that's really pretty neat. And also, you know, you don't have to worry about the claustrophobia and all the things people complain about in MRI because it just happens so fast. And so that's kind of attractive, especially for the 30% of people that we might not be able to get a good image for speckle tracking.
The MR angio is the future of cardiology. Are we heading to it?
Excuse me?
MR angiogram is the future of cardiology, like that's what you will be heading to?
Well, that's been the holy grail for a long time. You know, we've always been saying that MR of the coronaries we're just about there, which we've been saying that. I went to the first meeting of the Cardiac MRI Society in Atlanta about 25 years ago, and we were saying it then. And so every time it's like, you know, when people used to say, this year Jerusalem, well, we're saying now, this year it's going to be the cardiac MR. Well, you know that being on chemotherapy itself has been ranked as a risk factor for heart disease. And so hypertension, coronary disease, diabetes, family history of cardiomyopathy, and cardiotoxic chemotherapy is basically high risk for developing heart failure, and it's been classified by the American College of Cardiology, American Heart Association, as being Class A heart failure. You know, even though you don't have heart failure, you're at such risk that that's called Class A. And then Class B is asymptomatic heart failure, which would be abnormal speckle tracking if would be considered asymptomatic heart failure. And then symptomatic heart failure, and then refractory end-stage heart failure. And of course, we've all seen patients that have had anthracycline that basically cured their sarcoma, but went on to have severe congestive heart failure and cardiac transplant. And actually, the second transplant patient at Tampa General was Glenn Sperlin, who I had the pleasure of taking care of. Actually, I moved downtown to be there to stay and take care of him when I used to live in Carrollwood. And he is still alive today after like 23 years. And so it just happened to have, I think, a perfect match. But he had an osteosarcoma, was treated with adriamycin, and had severe cardiac damage. Of course, you know, there's a lot of research that's being done to try to take out whatever the moiety is on the chemistry, you know, that is causing the cardiac toxicity. If you can remove that moiety and still have effective chemotherapy, that is also an ultimate go. So here's patients who've had breast cancer, 63,566, and cardiovascular disease is the leading cause of death, 5.9%, followed by breast cancer, 5.1%. So that's pretty amazing numbers when you see that. And then here's congestive heart failure and breast cancer survivors, and the drugs that they've had, anthracycline being a big one, and the incidence of congestive heart failure in this group. And here's the cumulative incidence of congestive heart failure or cardiomyopathy, depending upon what the chemotherapy has been and what combination of chemotherapy. And you see there Herceptin, you see there anthracyclines, and you see the combination of both, and then you see none at the bottom. And so we're interested in predicting this. And so as you see, there's the SEER Medicare database, which has shown that there's an 18% 5-year incidence of congestive heart failure. And so for early stage breast cancer, a patient is more likely to die of heart disease than cancer. So those are things that get our attention as cardiologists, and you also as oncologists. You can see here cardiac toxicity with some of the other drugs, and as these drugs become more common, which I think hypertension is probably a marker of the effectiveness of some of these drugs. As they become more common and as the hypertension becomes treated and so forth, there is non-hypertensive cardiac toxicity that's also associated with them. And so that's important to follow these patients as well. This is the strain imaging spectral tracking that we talked about. Dr. Daniele Cardinale, who's at the Milan Central European Cancer Center, has studied troponin I as a marker, and the one they use is the ultra-sensitive or highly sensitive troponin I. And you can see there that incorporating strain imaging with the troponin I was more effective than doing troponin I alone, and in terms of negative predictive value. And so the two of those together, and so of course we're proposing the three of them together, and Dr. Linehan, who's at Vanderbilt University, has looked at B-type natriuretic peptide greater than 200 as a cutoff marker for negative predictive value of cardiomyopathy or early cardiomyopathy, and you can see it has a very strong negative predictive value. So we're pretty good on negative predictive value, not as good as positive predictive value, but negative predictive value is pretty important. And I think if we get all three together, we may be more effective. And then more troponin positive patients going through Herceptin cycles, and you can see the number of patients, 36 had troponin positives. You can see some have early troponin positives, some have later troponin positives as they go through the cycle. And so looking at this and following this is important because, as Dr. Chatur asked, the importance is being able to treat it. And so we do have the ability to treat this. And so this is an observation from Dr. Cardinale of patients in Milan who had troponin negative, and you can see basically the left ventricular ejection fraction and baseline, 1 year, 2 year, 3 year, 4 year, 5 year with a 6-year follow-up. And then patients who were troponin positive who were started on an ACE, the one they chose was enalapril, and you can see there's no difference. And so enalapril in these patients was an effective agent to prevent deterioration of the ejection fraction. And so that's what's surprising, is we have a way we can treat that now. And beta blocker is also useful. Here again, Dr. Cardinale with the control group, LV dysfunction, percent of patients, none of them on ACE at the time. In the control group, and use the controls, and then on ACE there's actually no LV dysfunction. Cardiac events, only 2% in the ACE group. Randomized controlled study. So recovery of LV dysfunction with standard heart failure therapy can be very effective using ACEs. And I haven't shown you beta blockers, but as you see here, beta blockers are more effective than ACEs. And here's the beta blocker. Digitalis was of no value. Phosphodiesterase inhibitors were not useful, and lodipine didn't help any. ACE inhibition was very, very useful, preventing mortality. Beta blocker was even better in terms of mortality and preserving ejection fraction. There are algorithms that have been developed, and this is an algorithm from our group there at MD Anderson. And what they're looking at is a change in strain, and if that strain drops below minus 12%, then that was considered significant. And so therapy was based on that. And then you've got those whose strain was unavailable, using the ejection fraction is the other technique. But subclinical detection with strain appears to be probably more useful. Here's another algorithm using an ACE for troponin I positive patients. And you can see that basically there's a preventive strategy, and then there's an early diagnosis and treatment strategy based on ejection fraction. And so we have a proposal that we want to bring to your group. And that proposal is basically in cooperation with Dr. Marwick, who was director of echocardiography at Cleveland Clinic. Dr. Plana is there now, director of echocardiography. And the idea, is to do a big study, multi-centers around the world. Take 20 centers around the world. GE is basically supporting this in concept, and Dr. Marwick is going to be the principal investigator. And we're proposing that Cleveland Clinic, Dr. Plana now, Dr. Marwick used to be his director there, MD Anderson, Dr. Bonches, who's my colleague that trained in Tampa, Mayo Clinic, who's Hector Villarraga, Washington Hospital Center, Anna Barrick, and then we're proposing this with the Florida Cancer Specialist and Cardiac Care Critique, which is our investigative group. And so the proposal is basically this, that each center would contribute 20 patients, and they would be randomized. And we have standard therapy, which is this arm, and we have strain therapy, which is this arm, and we compare the two. And of course, 20 patients aren't a lot of patients for the comparison, but when you multiply that times 20 centers around the world, we have statistical significance. And so that's really the plan that we would like to propose to you. That would be using GE strain equipment for measuring strain locally here in the accessible patients that you have locally. It won't take long to get to 20 patients, and so then we were proposing after that we would have a pilot project where we would take patients that are outside of the core group, which would be out here, that are inaccessible to us for doing strain echoing. These patients would be treated with standard of care, which would be regular echocardiogram, 2D without strain, and of course incorporate troponin I and B-type peptide. And these patients that are accessible to the core center here in Tampa, where we could measure strain on them, we would compare the two groups and the outcomes and follow them. That's another concept. Because strain hasn't made it to mainstream yet. Because most echocardiography groups aren't doing that. And Dr. Marwick, who's been involved in this for a long time, says that we just don't have the statistical significance that we really need to be able to demonstrate that this is the way everyone needs to go. But it won't take long with 20 centers, 20 patients each, to get to that. And then as soon as we got to where we thought that the strain needs to be everywhere, then we could have to work on putting high-quality strain imaging into these other centers. And we certainly can put B-type natriuretic peptide and highly sensitive troponin I into these centers now. So that's the idea we would like to consider. And so I've got some handouts to give you. And,
now is this in the form of a research protocol that patients have?
This would be a research protocol. And I've got a synopsis of the research protocol. for you to review here. So with Rita, who's our research coordinator, who's sitting over the table there. Rita, hold up your hand. With Rita, we'd like to work with your research team to try to put this together, both what we consider stage 1 and then the pilot project, which is stage 2. What you have is a synopsis of stage 1 there, which Dr. Marek has put together. So in conclusion, we've touched on a little bit of what we're calling cardio-oncology, and the change from having general echo labs record data that may not be consistent and has variable, probably variable supervision and acquisition, as well as variable people who are performing the test, to put it into a category of accurate observations are extremely necessary to maintain chemotherapy as you want it and as the patient desires it, and to detect early changes that may be prodromal of patients developing severe problems with their heart. We don't want people to inappropriately have to stop treatment because of inaccurate observations, or vice versa, continue treatment because of inaccurate observations. We also feel within the field that troponin I and B-type natriuretic peptide may eventually be a workaround and may perhaps give us information even more advanced and sooner than what the FDA requirements are at this time. So the American Society of Echocardiography is developing guidelines right now that will support strain imaging as well as 3D echo for following patients with chemotherapy and at fixed intervals, which will be accepted by the insurance companies because that will be the guideline or the standard of care. So we expect those to be out sometime in June or July.